The role of the speech pathologist on the Cleft Palate team is twofold. We work with infants to make sure that they have a safe and efficient suck, swallow, breathe pattern. We work with the older toddlers and children on making sure they have normal speech sound development and adequate functioning of the velopharyngeal mechanism.
In babies with cleft palate, the coordination of sucking, swallowing, and breathing can be more difficult than with other infants. That's why clinicians and parents often need to make accommodations to help these babies become more efficient feeders. The clinician starts by evaluating the child's anatomical structures.
We want to make sure that the tongue is contained in the oral cavity. The sucking pads will be present, and we want to look at the size of the jaw and make sure that the jaw is of normal size to contain the tongue within the oral cavity. It's also important to remember that in infants, the eustachian tubes are horizontal, and in infants with cleft lip and palate who may get a lot of formula up into the nasal cavity, this may lead to increased risk and incidence of ear infections.
Clinicians also need to assess the baby's oral reflexes. When you stroke the side of the cheek, the baby should turn toward the side that's stimulated. When you introduce a gloved finger, breast, nipple, or pacifier, the baby should begin to reflexively suck.
The gag reflex is elicited in the front 1/3 of the tongue in infants. The phasic bite reflex is elicited by using a gloved finger and stimulating the gum. The baby bites down on your finger. Reflexive sucking is present as early as 32 to 33 weeks gestational age, but we don't expect actual coordination of sucking and swallowing and breathing till 36 to 38 weeks gestational age. Infants are obligate nasal breathers. We expect them to breathe through their nose. This is extremely important in an infant that may have any anomalies of the nasal cavity.
Infants with an intact palate use negative pressure in a closed system to create suction needed to pull fluid back into their pharynx. But infants with a cleft lip and palate have an open system, making it much more difficult to create the suction needed to feed efficiently. Swallowing is divided into phases. The first phase is called the oral preparatory phase, where the clinician looks at how the baby receives the nipple or the breast into the oral cavity, how it's contained, whether the baby makes a good seal, if any liquid is lost, and if the baby is able to handle the flow. The clinician also looks at propulsion, the front to back movement of the tongue, and how the baby moves food from the front to the back of the mouth. An infant with cleft lip and palate may have difficulty with propulsion. The next phase in swallowing is the pharyngeal swallow. At this moment, the larynx and pharynx are in a resting position, the airway is open, and nasal breathing continues. The soft palate begins to elevate to close off the nasal cavity, and the swallow is initiated. A baby with an unrepaired cleft often ends up with nasal reflux, meaning formula or milk goes up into the nasal cavity, causing nasal congestion. This can cause the baby difficulty coordinating the suck-swallow-breath sequence. After the swallow is initiated, the food moves through the pharynx, the upper esophageal sphincter is open, which pulls the food into the esophagus, and swallowing is complete. When assessing an infant with cleft palate, there are a number of red flags to look for. First, breath sounds. Compare the baby's breath sounds during regular breathing with those during feeding. Wet breath sounds, congestion, sputtering, coughing, or choking may be signs of a possible problem. Another red flag is if the baby lets go of the nipple or if there is excessive loss of liquid. Number 4, if the baby has difficulty handling a change in flow rate. Last, it's also important to look for signs of apnea, bradycardia, or desaturations during feeding, which can indicate underlying swallowing dysfunction.
If an infant with cleft palate is exhibiting any red flags that may indicate underlying swallowing dysfunction, the next and most important step is to seek further evaluation and objective assessment of their swallow function. And this can take place via a modified barium swallow study, also called a video fluoroscopic assessment of infant swallowing, or FEES, fiber optic endoscopic evaluation of swallowing, to assess for the infant's airway protection during feeding.
Normal sucking is a reflex in infants. with a mature sucking pattern consisting of 10 to 30 sucks per burst. A baby with a non-syndromic cleft lip and palate should exhibit a similar reflexive suck. It's also important to remember that in an infant with syndromic cleft lip and palate, we would not expect them to aspirate.
We are able to make modifications to the mechanics of their sucking and the type of bottle and the flow rate that we have become really adept at making infants with cleft lip and palate be safe and efficient feeders.